Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha from Roots Community Health Center reporting for the week of June 19th, 2022. After a status update on the pandemic, including variants and vaccines, I will focus on children and COVID and the children's COVID vaccine. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Please submit your questions in the comments by direct message or by email to admin@rootsclinic.org. Here in Alameda County, we see that our 14-day cases continue climbing. We were at 10,937 last week. We're now at 11,120. So continuing to head in the wrong direction, although possibly slowing down a bit. We will just have to keep an eye on this, keeping in mind that for every recorded lab test, there are approximately 8 more positives that are detected through home tests. So we know that this is a drastic undercounting, so we continue to keep that in mind. Our 7-day percent positivity rate also continues to increase. We're at 11% positives. The hospitalizations are down a bit from when I reported last week, which is good. Unclear whether it's coming down or whether it's going to be doing this little fluctuating up and down that it's been doing for a bit. But we're at 104 people in the hospital with SARS-CoV-2 compared to 112 last week. But there are still 12 in the ICU. That remains unchanged. So because of the dramatic undercounting that we know we have with cases, we always want to look to other sources to get a sense of what's going on. One of those is the wastewater sampling. And we can see here, this is from East Bay MUD, the East Bay Municipal Utility District. And this is getting wastewater sampling and seeing how many copies of SARS-CoV-2 are in the wastewater. And unfortunately, we can see that this is just continuing to go up. So this hasn't quite been perhaps as useful as we would have liked it to been. I think we're still learning how to best use this information. But certainly, again, we can look at the direction and see that it's not going the direction we would like it to. So we'll have to keep an eye on that. And the Oakland Unified School District has not updated their dashboard since May. So with school being out, I think we can guess that that may not be a resource for us until after school is back in session. And so when we think about the wastewater and where the cases are and so forth, I think it becomes more and more clear that how we're doing locally is very important in terms of shaping a local response or understanding how risky our activities might be at this moment. And one thing I wanted to point out is that we still do have significant disparities in terms of vaccination coverage. Our lowest vaccination rates in terms of zip codes are in Oakland and the unincorporated area and Hayward, so 94605, 94578, and 94541. These are some of the zip codes that were also hit with highest case rates earlier on, but we can see that they're all under 80% vaccinated, and we know that several other zip codes are in the high 80s and even in the 90s. So we have some work to do. We also know that in our African American and Latino populations, only about 70% are fully vaccinated, leaving 30% unvaccinated. So all of this to say that within certain communities, when there are outbreaks, it will be faster to spread among unvaccinated individuals. And so this is just something to keep in mind in terms of how much work we have left to do. The same is true when we think about our younger children, our 5 to 11-year-olds, who are still the lowest vaccinated population. So again, when we're thinking about sports and camps and summer school, where you have larger groups of unvaccinated individuals, is more opportunity for more spread, which is what we're concerned about, not only for poor outcomes, also for long COVID, also for the development of new variants, which we would really like to avoid. And of course, we have to keep an eye on our hospital capacity. So far, we have not run into any issue of not having sufficient hospital capacity, but even by the CDC's more pastel optimistic map, you can still see that Alameda County and several surrounding counties are now considered to be in the high community level zone, meaning that there's concern around our number of new hospital admissions as well as hospital capacity. So this is something we want to keep a close eye on, because it's not just about Alameda County. It's also about our surrounding counties and wanting to make sure that we maintain adequate capacity there. And even by the CDC's more optimistic map here, we are in that more danger zone of the high community levels. The transmission map is very red at this time. I'm not going to show it right now, but we have high transmission in over 80% of the country at this time. I do think it's worth noting that in about a week, BA4 and 5 went from about 11-12% to about 21% of cases. So it's definitely moving quickly. So we'll just have to keep an eye on that. Just a reminder about the recommendations for boosters is that the first booster for everyone 5 and up should happen at least 5 months after the primary series. If you haven't gotten that first booster and you're over 5 and it's been at least 5 months since the primary series, now would be a great time to go ahead and get caught up. And if you're over 50 or 12 and up with immunocompromised, if it's been 4 months since your first booster, it is time for your second booster. And it looks like, again, now would be a great time to get that done, because there's quite a bit of COVID circulating around. And unfortunately, while the vaccine is protecting from the most severe outcomes, in particular with our elders, we're pretty concerned about those who've yet to get their boosters. So please encourage your loved ones and strongly consider it for yourself if you fall into those eligible groups. So I want to spend a little time talking about kids and COVID and the vaccine, because the vaccine for 6-month to 5-year-olds was recently approved. There was a 2-day meeting on June 17th and 18th of the Advisory Committee for Immunization Practices, which advises the CDC, and they have unanimously approved the Moderna and Pfizer vaccines for our youngest little people, 6 months to 5 years of age. And so this is a big step, but there's also a lot of questions that folks have about whether this is important to do or not. And so I just want to walk us through the thinking about the relevance of having a SARS-CoV-2 vaccine for our 6-month to 4-year-old children. So first off, just how COVID has impacted our kids directly, and especially the littlest ones. So under 1 year old, we've already had over 570,000 cases of SARS-CoV-2. And in the 1 to 4-year-old age group, we've had over 1.9 million cases in the United States of SARS-CoV-2. And when you look at our 5 to 17-year-olds, we're talking about another 10.8 million cases in this group. So with a novel virus, with some things that we know are affecting people even after they catch it, this is a pretty heavy burden of infection in the first place. So that is something to keep in mind. Children have not obviously been protected or immune from this virus. And when Omicron came along, that led to incredibly high numbers of COVID-19 cases. And it also, we saw the highest emergency department visits and hospitalization rates seen for the entire pandemic. And this was disproportionately true for our children as well. And I'll show some slides in a moment on that. But it's important to know that among children in this age group, the 6-month to 4-year-old group, that there were hospitalizations and there were severe cases of SARS-CoV-2. So we know that 6-month to 4-year-olds are at risk of severe illness from COVID. And I'll walk through a little bit of that now. So you could see here that from March 2020 to March 2022, these are hospitalizations for our children. And it's broken out by the age groups you can see there. But what I wanted to point out here is that, first of all, in Omicron, it got pretty serious. We had a lot of little ones in the hospital. Hospitalization is not a small thing for these little folks. It can be something that can impact them for years to come. And when we look at our 6-month to 4-year-olds, you can see that during Omicron, there was a significant crossover where that group experienced by far the highest number of hospitalizations. So our little tiny ones ending up hospitalized. And that trend has continued where that group is much higher than the other groups. And that is attributable in large part to the fact that the vaccine became available for those 5 and up around that time. And so we saw our 6-month and 4-year-old hospitalizations surpass the other groups. And you can see this here, looking at the cumulative cases, you can see the clear kind of crossover that sort of happened there around the time of the Omicron surge. So this is something that is worrisome, and it's something that if we have the opportunity to stop it, that's what we would want to do. And another thing to know is that these children got quite sick, even when we compare it to the older children. So when we look at that younger age group of the under 4s, almost a quarter of them who were admitted actually went to the ICU. So pediatric ICU, where we do often, we can run into capacity issues compared to adults, because we don't tend to have a lot of kids having to unfortunately go to the hospital like this and go to the ICU. And so this is very stressful for the babies, for the families, and for hospital staff to have our littlest people getting this sick from a respiratory and from a contagious virus like this. And so one question that always seems to come up was, well, did they get admitted for the COVID, or did they get admitted for something else and then find out they had COVID? So sometimes this distinction isn't really that important, because oftentimes, even if COVID wasn't the first thing that got them admitted, it can be the thing that keeps them there longer or that makes them much sicker. But even if we want to talk about just the reason why they went to the hospital, you can see here that in the 6-month to 4-year-old age group, 87%, they were primarily admitted for COVID. So this is very significant. Majority of hospitalizations for COVID were for COVID. It was not an incidental finding. It wasn't a later finding. They didn't just catch it later. That is the reason why they were admitted. And this is highly concerning. And this tells us that SARS-CoV-2 absolutely can be a serious condition even in our children. So the other question that comes up, well, was they must have had underlying conditions or something else wrong with them, which is, it's a pretty concerning thing to be hearing for a couple of reasons. One is because I don't think most people realize just how many of us may have underlying conditions. And so oftentimes people don't understand that overweight or obesity is a significant risk factor. And this is true in children as well. But even if you are to look at whether they had even one underlying condition, you can see here that more than half, so those gray bars there, more than half of children 6 months to 4 years old who were in the hospital for SARS-CoV-2 did not have any underlying medical condition. None at all. And so when you have over half of children admitted had no underlying condition, 87% of them admitted primarily for SARS-CoV-2, you begin to see the picture that this is not a benign issue in children, and that unfortunately we cannot predict which children are going to do poorly. The majority of them did not even have not even one underlying condition. So this really should give us all pause, because this is very counter to the narrative that we've been hearing. The narrative is wrong. We cannot predict who's going to do poorly from SARS-CoV-2, and that is why this is something we should continue to take really seriously. And unfortunately, as we know, some of these babies do not survive. And What is really striking is that COVID-19 made it into the top 5 list of causes of death for all of the pediatric age groups. So it is not that often that you have a new cause of death make it into the top 5 so quickly. And so you can see here that under 1-year-olds, COVID-19 became the 4th leading cause of death. And same with the 10 to 19-year-olds. And in the 1 to 9-year-olds, it's the 5th leading cause of death. So it's pretty unusual for anything new to make it into the top 10, 11 causes of death. So to have something we never even heard of a couple of years ago, now being number 4 or number 5, not just in our elders, in our babies, this is very serious business. And it's quite striking, really. And when you take a look at what those other causes of death are, you can see we've got accidents and congenital issues or chromosomal issues. We've got cancers in at number 3. Number 4, sadly, assault or homicide. And then number 5 is COVID. A couple things about this that I want to say. First, again, striking to see any new cause of death, but in particular that it is a infectious disease. So you can see it is the only infectious cause of death on this list. So in 2019, we weren't seeing a lot of children dying of infectious causes. We would typically see flu in the top 10 in some of the younger age groups that are too young to be vaccinated. But as a general statement, infectious causes are usually not what is killing children. And so to see a new infectious cause in the top 5 is concerning, and we would want to do what we could to eradicate that. The other thing I want to point out is that most of these other causes you see here are not just one thing, right? Cancer is not just one thing. It's a variety of different types of it could be solid tumors, it could be leukemias, lymphomas. So it's a whole constellation of things that you add them all up together and you end up being in the top 5. Also, same with congenital issues and chromosomal issues. These are all a whole array of different things being lumped into one category. And even accidents. Could be automobile accidents, could be drownings, could be a number of different types of accidents, poisonings, and so on. So those are all being lumped together into one thing, but COVID is not being lumped together. It just is one thing. And so we're really looking at COVID itself being a leading cause of death in these young age groups and being the only infectious cause. So these are all important things to take into consideration. So what does this mean? Does this mean what should we do? Should we vaccinate against this? How does this stack up to other infections that we regularly vaccinate our children against? So our routine vaccinations, if we take a look at these diseases for which we routinely vaccinate our children, and you can see the comparison of deaths per year, and take a look at, you can see the ages there as well. So if you take all the young people under 20 dying of hepatitis A, all the 11 to 18-year-olds dying of meningococcal disease, all the 5 to 9-year-olds dying of varicella, and so on, you could add all those up and it will not equal the number of children in the 6-month to 4-year-old category who are dying of COVID-19. So it makes it seem like a real no-brainer when you consider the fact that we routinely vaccinate for infectious issues, and that is why kids are not dying from them. So when we have a vaccine to stop children from being hospitalized and dying, then that's what we do. We vaccinate them. And you can see here that all these routine causes all put together don't even add up to the number of 6-month to 4-year-old children that have unfortunately died from SARS-CoV-2, and that is average deaths per year there. That's not the entire period, but it's per year. And everything that I've just reviewed isn't even talking about the later effects of SARS-CoV-2. So we know that we have multi-system inflammatory system syndrome in children, MIS-C, multi-system inflammatory syndrome in children, which even after a mild case of COVID can cause multiple of the organs and systems in a child to become inflamed and even fail. And we have had over 8,500 MIS-C cases. So that's not even included in what I presented before. And we've had 69 deaths from MIS-C as well. And so, and then that's also, again, not talking about long COVID, which we're still trying to really wrap our arms around, all of the post-COVID phenomenon that happened and how long can these things affect someone's health, and particularly a child. We don't know yet, but we do know that there are incidences of myocarditis, incidences of just neurological issues and psychological issues, as well as respiratory and cardiac issues following COVID. So everything, and the slides, by the way, that I was presenting earlier are all from that Advisory Committee on Immunization Practices data that they reviewed in order to arrive at their recommendation. And again, those hospitalizations and deaths did not include the MIS-C cases and deaths, and it doesn't include any burden of anything post-COVID. So it was just talking about the actual infection itself. And so these are all things we need to take into account as we consider the importance of the vaccine. And one thing that I want to point out is that in the Omicron wave, where I mentioned that we saw a lot of hospitalization, a lot of infection, a lot of ER use, is that a lot of people are saying, well, my kid caught it, during the Omicron wave, aren't they protected? And as I reported here before, unfortunately, the subvariants of Omicron that we're dealing with now are not the same ones that we were dealing with in December, January. So now we've got BA.2.12.1, got BA.4, got BA.5. These are more immune evasive. So unfortunately, that infection acquired immunity, those antibodies that you might have gotten from an Omicron infection, are just not holding up against these newer subvariants. And there is ample data that is demonstrating that those who are vaccinated are much less likely to be reinfected compared to those who were just previously infected and were not vaccinated. So we still know that the vaccine is what gives us much more reliable protection, particularly against the most severe outcomes. And that unfortunately prior infection right now just isn't cutting it, and folks are getting reinfected especially if they're unvaccinated. So what did the committee review? They reviewed 2 vaccines. They reviewed the Moderna vaccine for children 6 months old to 5 years old, and they reviewed the Pfizer vaccine, and that is for those 6 months old to 4 years old. And the Moderna trial was conducted from December 2021 through February of 2022, so during the Omicron period. And they basically were testing out a 25 microgram dose, so much smaller than the adult dose, a quarter of the adult dose. And it's 2 doses, 28 days apart. And they followed up 2.5 months after dose number 2. And the population that they studied, they had 2,300 children in the 6 to 23 month old category, and another 4,000 in the 2 to 5 year old category. So fairly significant size trial, 6,300 children from 6 months old to 5 years old. And they checked the safety, of course, and safety really we did very well in the safety category, and the bigger concern really was around how effective is this. So let me tell you what they found. And in order to test the effectiveness, they both looked at a subset of children within this study population, and they also did immunobridging, which I've described in prior briefings as a way of taking a look at older populations and kind of making a bridge to be able to understand what they can glean from a smaller population size in the age group that we're studying. So what we found is that in terms of safety and tolerability, that the vaccines were very safe. There were no cases of myocarditis. And it wasn't a surprise this time because we also didn't see a safety signal for the 5 to 11-year-olds either. Remember, myocarditis is the inflammation of the heart. That is a rare side effect that is self-limited. People recover well, but it's usually in the young men population in particular, so around that 16 to early 20s age group. And the incidence of myocarditis after the vaccine, first of all, has been greatly reduced with the new vaccine schedule for older children and adults. It's now 8 weeks between dose 1 and dose 2, but also the risk of that is far, far lower than the risk of myocarditis from actually catching SARS-CoV-2. So, but also to note that in this particular age group, we do not see any myocarditis. So that is very good news and is not a consideration as you weigh out getting this vaccine for the 6-month to 5-year-old group. The main side effect that was seen was fever, and fever was more common after the vaccine, about 16% in the vaccine group compared to 7% in the placebo. But remember that many of our childhood vaccines actually do result in fever. In fact, some of the vaccines, like a third of children will end up with a fever. So this is not something that is unusual. Most of the time, the fever lasts for 1, maybe 2 days. It lasts at an average of 1 day in the Moderna group. And when they took a look at the antibody levels after the 2-dose Moderna series in the 6-month-old to 5-year-olds, they found that there was a similar antibody response after the 2 doses as when we compare it to the 18 to 24-year-olds. And this was looking at the Omicron time. So the performance against Omicron was very similar to the other age groups as well. So we're not in that spectacular 95% like we were when we first got these vaccines and we were against the wild type strain. With the way things have evolved, it's getting pretty difficult to even get a straight percent like that, because now we have vaccinated, unvaccinated. We have a short time after vaccination, a long time after vaccination. We have boosters. We have people who've gotten infected and then vaccinated, vaccinated, then infected, infected, vaccinated, infected. So there's so many variables that it's getting pretty much impossible to do real good apples to apples comparisons. So what we have now is really a demonstration that among children, the vaccines are very safe and they are producing an antibody response that is similar to the older age groups. And so there's every expectation that this is protective. One of the challenges with the children vaccine trials and why it can really take longer and be a little harder to arrive at some of these hard numbers is because the number of hospitalizations and deaths that we see here, the percentages are lower than, let's say, when we did this in our 80-year-old and up individuals. So it would take a lot longer to be able to compare those who got the vaccine and those who didn't get the vaccine in terms of death and hospitalization. It's going to take a lot longer than sort of that 2 to 4 month study period. However, it's not necessary to arrive at those endpoints for this age group because we're able to do the immunobridging, and because we know that we have the safety, and because we can see that we have the immunogenicity, or the production of the immune response. So with all of those things taken together, we have a safe and effective vaccine for our 6-month-old to 5-year-olds in the Moderna. The Pfizer, this trial went on over a longer period of time. It was June 2021 to April 2022. This is not because it was necessarily a better trial or anything like that. It has to do with the fact that they started with a pretty small dose, and that dose turned out to be safe. So it passed all the safety parameters. However, the 2-dose series was not giving a good enough response. So they did not present it basically for approval because they didn't get enough of an antibody response. And what they did was a 3 microgram dose. What dose 1 and dose 2 were separated by 21 days. So what they then did was go ahead and add a 3rd dose another 8 weeks later. So now you have an interval between dose 2 and dose 3 that is longer. So it made it a longer trial, and it also means it will be longer before you would be fully protected if you were to go the Pfizer route. And so then they did a follow-up, a post-dose 3 follow-up for 1.3 months, so a little shorter than what they were able to do in the Moderna trial. And there was this effort, I don't know how I feel about it, but there was this effort to get Moderna and Pfizer synced up so that they would get approved at the same time. Some people feel like this led to an unreasonable delay in getting Moderna passed, but we're here now. We've got 2 choices. They're a little different in terms of 2 doses versus 3 doses. The Moderna is they're higher doses, a little bit more reactogenic, so a little bit more in terms of that fever and side effects, which is the same thing that we saw in adults. Moderna gave a little bit more of a reaction, but it also gave a little bit higher protection. And once again, we can't really compare head to head at all, because now we've got 2 different time frames of the study, and we've got 2 different dosing regimens. We've got 2 doses versus 3 doses. So the committee essentially determined that these are both very good choices, and they have no reason to prefer one over the other. So kind of by way of review, Moderna and Pfizer were both shown to be very safe. There was no cases of myocarditis in any of the trial participants in either of the trials. There was also no anaphylaxis, so no vaccine-associated anaphylaxis or severe allergic reaction in any of the trial participants in either of the trials. And both of the vaccines met the criteria for antibody levels, and what they call it is non-inferiority criteria. That just means it didn't do worse than the older age groups. So it met non-inferiority criteria, both of them, for the antibody levels. And so they're both very decent. In order for us to say what percentage protection we get against hospitalization and death, again, because these are children, the trials were not large enough or high powered enough to be able to show us that. And I think that was to be expected. Yet we have very good safety, and we will get a lot more of that nuanced information as we go, but we're all going to have to be a little patient and realize that it's not going to be this super clean information. We're going to have some children that were infected and vaccinated, some that were only vaccinated, and so on. But we can see very clearly that getting vaccinated is protective, it is producing those antibodies, and it is safe. Now, as far as Pfizer versus Moderna, I think that there's going to be pros and cons to each of them. Basically, most pediatricians out there, many pediatricians have been vaccinating the 5 and up age group with the Pfizer already, so they may feel more familiar with the Pfizer. So you may see that your pediatrician's office may decide to only carry Pfizer, for example. However, longer term storage does require those ultra low temperature freezers, which not all offices have. And it also needs to be diluted. And with the Moderna vaccine for the 6-month-old to 5-year-old, maybe pediatricians' offices, well, maybe they'll be less familiar and therefore less likely to order it. However, it can be stored long-term in a regular freezer. So this may become eventually a better option for a lot of pediatricians' offices. It also does not need to be diluted. So there may be different reasons why your doctor decides to carry one or the other. At Roots, we will be carrying both, and I'm sure at many of the vaccine sites, they will be carrying both just because there's preference involved. There's also the timeline involved, and so it's going to take a lot longer to be fully covered with the Pfizer compared with the Moderna. So some of this is going to be a preference, and also whether you think you'll be able to reliably make it for all 3 appointments, or whether you'd rather just get it over with in 2 appointments and get more quickly protected, or whether you'd rather wait a little longer. And again, time will tell. There may be a theoretical advantage, or there may be a real advantage, it's theoretical at this point, to having the doses spread out further apart. But again, it's a lower dose, so this all remains to be seen. We're not doing the apples to apples comparison. We're just saying that right now, both of these are completely viable options, and it's probably going to be about what is available to you and what works the best with the timing. And so with this expansion of vaccines being recommended down to 6 months of age, this is making eligible another 18.7 million children to receive a primary COVID vaccine series. Now our only fully unvaccinated population will be under 6 months old. And this is typically a group of people that is inside more and hopefully exposed less, and hopefully increasingly will be around people who are vaccinated and protected. And so we'll be able to protect that small group in that way. We want to make sure that everyone getting vaccinated registers for vsafe. The link is in the post, and that goes for adults and children. We want to make sure that any side effects or anything like that, you have a good way to report those so that we can understand and add to the body of information that we already are gathering, and we can build upon that. And the other thing to know is that the COVID vaccine can be administered simultaneously with other vaccines. So that is not something that you have to worry about spacing out. They can be administered at the same time. However, if we have other vaccines that can tend to cause a little bit of a local reaction, your pediatrician's office may choose to administer them in different arms, different legs, just depending on the age of the child and so on. And that is not unlike our other routine vaccination schedules and how we administer multiple vaccines sometimes for our little ones. So children 6 months to 5 years old are at risk of severe illness from COVID-19, and we can't predict who's going to do poorly and who's going to do okay, and we can't predict who's going to get long or post-COVID issues, but vaccination is reducing the risk in adults of those post-COVID and long COVID issues, and we anticipate that that will be the same in the 6 month to 4 year olds. COVID has already caused over 2 million cases in this age group of 6 months to 4 year olds, 20,000 hospitalizations, and over 200 deaths in this little age group. And more than half of those hospitalized children 6 months to 4 years old had no underlying conditions. And COVID-associated hospitalization among this age group has been oftentimes more severe, even compared to older children, with a quarter of these babies going to the ICU. And we know that the burden of COVID-19 associated death is higher than with our other pediatric vaccine preventable diseases. So it is very good news that COVID has now entered into the realm of a at least vaccine preventable death and a oftentimes hospitalization preventable situation with this vaccine. We know that unfortunately these vaccines are not halting transmission the way that we had hoped, but that was not ever our endpoint. Our endpoint was to keep people out of the hospital and keep people from dying, and this goes for our children as well. So if we can wipe this cause of death off of that chart of top 5 causes of death, that is absolutely what we need to do. Prior infection is not giving us the protection, that broad protection that we need for variants. We will have future surges. We're in a surge now, and these surges will continue to impact our babies, and our unvaccinated children are at much higher risk of severe outcomes. And let's just keep this in perspective. Kids should not be going to the hospital and dying of infections. This is 2022. And before COVID, we didn't hear about that very often, a child dying of an infection. And why? Because of vaccines. So now that we have a vaccine, we should be able to get this thing off of our top 5 causes of death in short order. And we really want to do that as quickly as possible so that we don't see what we've kind of begun to see, which is that children are making up larger proportions of hospitalizations. And we're even seeing in South Africa recently reported that in their springtime wave that they just had, that children under 9 comprise more hospitalizations than the over 80-year-old age group. So that's an unacceptable state of affairs when we have an available vaccine. So we need to get onto this task of vaccinating everyone 6 months and up. Remember, we're still behind on our 5 to 11-year-olds as well. And so this is something that we should be paying attention to. And I have to say, and this is not meant to disparage any of my colleagues and fellow primary care doctors out there, but I am talking to my community right now and letting you know that do not accept pushback about treatment, about vaccines, just because your doctor might not be up on the latest or carrying it. Let's make sure we're advocating for ourselves. And if there is any way to get them more information so that they can be up on it, let's help them do that. Because right now, primary care doctors are pretty overwhelmed with all the regular stuff we have to deal with. The fact that people have put off care for other things for so long, and we're having to catch up. The fact that children are behind on their other vaccines, and we're having to catch up. And it is practically a full-time job, I'm telling you from experience, to keep up with everything with COVID. So let's cut them a little slack and know that they may not have all the super latest and greatest. And so if they tell you, no, I don't have the vaccine, or I'm not sure if it's important, or no, you can't have Paxlovid because I don't write for Paxlovid, these are all not acceptable answers right now. However, right now, while we're trying to get everyone ramped up and get everyone up to speed, unfortunately, that is what we're hearing. So I am just asking for everyone to inform themselves, advocate for yourself, advocate for your loved ones. Right now, we would like to see everyone who can be protected from SARS-CoV-2 get protected. And the best way to get protected is to get vaccinated and to continue to mask and to continue to be mindful of your indoor spaces, spending shorter time indoors with people outside of your bubble, making sure that you're in well ventilated spaces, and doing your eating and drinking and so forth outdoors. Gather outdoors when you can. Outdoors is not foolproof. So that doesn't mean crowd outdoors and get in each other's faces like we're seeing with the parade and with concerts and other things going on. Take you a mask, and if you cannot space, go ahead and put the mask on, even though you're outdoors, because we are hearing more and more people catching it outdoors. And if you're the only one inside masking, especially important that you be wearing an N95 or at least a KN95 mask. And we want to make sure to open windows and get the HVAC going, upgrade our indoor ventilation and air quality, and of course, to prevent the most severe and tragic outcomes of SARS-CoV-2, vaccine and up to date on your boosters. Still remarkably effective at allowing you to survive even in the event that you do catch it. If you don't have a primary care doctor, please get one and advocate for yourself. Make sure that they're carrying the vaccine. It's available to you. If they don't have it, find a place in the community that can get it for you. Vaccines.gov has a locator. They have added the age ranges on there. The link is in the post. All of the counties have, give them a minute to update their sites, but they're all going to have the child vaccines on there. They are shipping as we speak, so most of us will have them any day now. And so these will become available to you. And we want to encourage you to get all of your questions answered. So please send those questions to admin@rootsclinic.org. We'll be happy to answer them. And in the meantime, please get some fresh air. It's beautiful out there. Eat a balanced diet, exercise, manage your stress levels, consider a multivitamin supplement with additional vitamin D supplementation. Get your primary care doctor and get those vitamin D levels checked along with your sugar, cholesterol, and all the other routine screenings that we need to get. and make sure to get a good night's sleep. Thank you so much for joining us, and we look forward to seeing you again next Tuesday at 10 a.m. See you then.